So it was a study over 3 years where nearly 27,000 young individuals aged 14 to 35 years self-presented to screening, which was conducted by the charity Cardiac Risk in the Young, which is a well-established screening program throughout the United Kingdom. All individuals underwent a screening conducted by a cardiologist, and it was consisted of a personal and family history, physical examination, and an ECG. Individuals who were found to have positive screening tests were referred on to hospitals in their local vicinity for further investigations to confirm or refute the diagnosis of cardiac disease. The ECG is, as a screening test, is a very controversial topic. It's not universally accepted. In Italy, a country where ECG screening of athletes is mandatory by law, a study has reported an 89% reduction in the frequency of sudden cardiac death over 25 years. However, in the United States and several other Western countries, ECG screening is not implemented at state level. However, in many sporting organizations, especially the financially endowed ones in the United Kingdom, ECG screening is routine.
But these were not necessarily athletes.
Yes. So this particular study is the first comprehensive evaluation of cardiovascular disease screening outside the context of competitive sport. This is important because there is now emerging evidence that actually young individuals who are not competitive athletes may be at higher risk of sudden cardiac death than previously thought.
And what was the yield? What did you find?
So following comprehensive evaluation, we found that 87 individuals, equating to a prevalence of 0.3%, were identified with a condition implicated in young sudden cardiac death at 2 years follow-up. So the costs were based on the United Kingdom National Health Service tariffs, and we found that the cost to identify an individual through this program was approximately $110 per person, and the cost per serious condition identified was just under $34,000 per condition. Long-term follow-up of these individuals is the only way we can determine the true cost effectiveness of early identification of disease. However, we have to consider several things. Firstly, the age of the individual identified with disease. We know that, especially in young athletes, the age of sudden cardiac death, the average age is nearly 18 years of age. So the loss of decades of potential life from a condition that can be detected during life and where acceptable interventions are available that may reduce the risk of sudden cardiac death has to be considered when we think of cost effectiveness. Secondly, these are genetic conditions. Identification of one individual from a screening program generates the potential to identify other individuals within that same family, and that will also have a positive impact on cost effectiveness. So serious cardiac disease are those conditions implicated in young sudden cardiac death. We know that in nearly 40% of sudden cardiac death in young individuals, the heart is actually normal at post-mortem. These conditions are commonly attributed to ion channel diseases such as Brugada syndrome, long QT syndrome, and catecholaminergic polymorphic tachycardia. Certainly, Brugada syndrome and long QT syndrome can be diagnosed on a resting ECG. In other parts of the world, so for example in Italy, arrhythmogenic right ventricular cardiomyopathy is the leading cause of sudden cardiac death, whereas in the United States, hypertrophic cardiomyopathy is the leading cause of death in young individuals. The benefits of the addition of the ECG to history and physical examination would comfortably allow affordability of the additional tests in individuals identified with disease, such as genetic testing, risk stratification, and familial evaluation, and still be cheaper than what we would expect the cost to be had evaluation only been reserved for individuals who had abnormal symptoms or a family history.